Aditya Yerrapragada. I'm one of the new foot and ankle orthopedic surgeons here at Boulder Center for Orthopedics. I'm happy to be in the Boulder area and the Front Range in general, and look forward to meeting everyone and seeing everyone in person. So who am I? As Sally mentioned, orthopedic foot and ankle surgeon. I grew up in Texas and went to undergrad at University of Texas, Austin, did my medical school training at the University of Louisville in Kentucky. I spent 5 years in Seattle, Washington at the University of Washington doing my orthopedic surgery residency, and spent an extra year specifically training in orthopedic foot and ankle surgery in Baltimore, Maryland. I specialize on a lot of conditions foot and ankle related. That includes Achilles tendon reconstruction, ankle arthroscopy, arthritis care, bunion, hammer toe surgery, cartilage repair, restoration, flat foot reconstruction, joint injections, a lot of different minimally invasive surgery techniques, surgical fracture care, and total ankle replacement. But when I'm not operating, I enjoy spending time with my 2 young boys, my lovely wife, spending time outdoors, snowboarding, hiking, traveling, all the above. I'm trying my best to fit into the active Front Range community. So the general overview of mine and Chelsea's talk is I'm going to talk about some very common sports-related foot and ankle injuries: ankle sprains, Achilles tendon ruptures, peroneal tendon tears and instability, and common fractures. Throughout our talk, I'm going to plan on introducing the topic, talk about some general findings that you expect to see, and Chelsea will jump in with some physical therapy perspectives on both non-operative and operative treatment options. And of course, please ask questions in the comments and we'll address these questions at the end of our talk. So first, I'm going to start with ankle sprains. And ankle sprains are the most common reason in orthopedics for missed athletic participation. Typically results in an inversion injury, as you can see on that diagram to the bottom left. And it involves spraining or tearing of 2 main ligaments in the front aspect of your ankle: a ligament called the anterior talofibular ligament and the calcaneofibular ligament. A variation of ankle sprains is called a high ankle sprain. You've probably heard of a lot of athletes with this type of injury. It comprises about 10% of ankle sprains, and it's a slightly different mechanism. It's an external rotation of the foot with a planted leg. It's usually a higher energy mechanism and involves tearing or injury to a different set of ligaments of the ankle, what we call the syndesmosis, which is the connection between your fibula and your tibia. So a subtle difference in terms of the type of ligaments that are injured. When you have an ankle sprains, the presentation can be very different. All sprains are on a spectrum. Some can be very mild, some can be very severe, and they can often feel like a fracture. You can get significant bruising, swelling, and pain, particularly on the lateral side or outside of the ankle. And depending on how bad it is, you may or may not be able to bear weight, and often feels like a fracture. So the next question, logically would be, is it an ankle sprain or is it a fracture? It's oftentimes very difficult to assess that because pain is often just as severe, especially immediately after the injury. So when should you get an x-ray? When you can't walk on it, even after a few days, there's a chance it might be broken. If you have point tenderness directly over a bone, either on the outside or inside of your ankle, or you just want to know. And in general, my philosophy is when in doubt, get an x-ray. If you get an x-ray, you know what it is or isn't, and it gives you some peace of mind in terms of treatment going forward. These are all sample x-rays of what you might find if you were to sprain your ankle. The x-rays on the left 2 x-rays are actually normal x-rays, no fractures, nothing broken, which is a typical x-ray after getting an ankle sprain. But the x-ray on the top right and the bottom right with the arrows show small fractures, what we call avulsion fractures, where instead of the ligament tearing or rupturing, it actually pulled a piece of bone off of either the front of the talus or bottom of the fibula. All of these are consistent with ankle sprains. A subtle difference is a high ankle sprain. And what you'll often find if you are concerned or have suspicion for a high ankle sprain is you'll probably get a stress x-ray. And what you're stressing are the ligaments between the fibula and the tibia, the connection between those 2 bones. The x-ray on the right shows a normal overlap between the bones, and an x-ray on the left shows a stress x-ray, which shows gapping between these 2 bones, indicative of a high ankle sprain. So general treatment for ankle sprains, first-line treatment is always conservative, regardless of the severity of the sprain. The only exception is high ankle sprains with instability on x-ray often need surgery. The first line treatment options include rice. Everyone knows rice, ice, compression, elevation, plus anti-inflammatories like Advil or Aleve. Oftentimes, I put you into a walking boot. You can bear full weight in the boot, and it keeps the ankle stable during weight bearing, preventing foot rotation, which can exacerbate the injury. It allows the ligaments to scar in over time as well. A next step down from the walking boot is the lace-up ankle brace. Sometimes a first-line treatment for mild sprains, but often the next step after transitioning out of the boot. And of course, physical therapy is incredibly important. And this is where I'll ask Chelsea to jump in and give her thoughts on therapy for ankle sprains.
All right, so for physical therapy for an ankle sprain, when you first come in for the exam, just so you know what to expect, it'll consist of the therapist asking you questions about your injury and also that physical exam. Questions that they might ask you are, how are your activities limited? What has been helpful so far in your recovery? And what do you want to get back to doing? The physical exam will vary depending on your limitations, but at a very basic level, the therapist will evaluate your motion, strength, balance, and potentially some of the activities that you would need to do in your daily life. Again, all of this will be dependent on, are you in a boot? Do you have restrictions in weight bearing and all of that? Examples of activities you might do during your daily life would be getting up and down from a chair, stepping up and off a stair. All of this will help to direct your therapy so that it is focused on you as an individual. The initial phase after an ankle sprain or really any injury is the acute phase. This is shortly after the injury, in this case, the sprain. And during this phase, the body will have an inflammatory reaction and will be bringing healing material to the site of the injury. The main focus of this is protecting the injured tissues and controlling pain and swelling. We can do this in several different ways. Manual therapy can be helpful during this phase to reduce swelling and to improve circulation. We can also help to restore lost motion. Exercises for home during this phase might be ankle pumps or alpha beds. Generally, we're just trying to rest the tissue during this. During the intermediate phase, the tissue has increased instability and can be loaded more. It is actually helpful to start loading that tissue so that your body knows where to reinforce when laying down the healing materials. Progressive motion is important to work towards, as well as restoring strength and balance. Balance is important with any of these injuries that we're going to talk about and will be discussed in further detail later in the presentation. But examples of exercises that you might encounter during this phase would be heel raises, resisted ankle motions with a band, or even single leg balance. The final basic phase of rehab is the advanced or return to sport or activity, depending on what you told your therapist. And this is why that discussion at your evaluation is helpful, so that your therapist can make sure that you're working towards these goals of returning to the activity of your choice by the end of your therapy. Depending on what you want to return to, this phase of the rehab might include additional strengthening, running progression, and plyometrics or jumping related activities. The use of bracing during this phase and in the future will be individual and would be based on the recommendations by the surgeon. Progression through these phases is dictated not only just by tissue healing time, so you need to be so far out before we start loading that tissue, but also by criteria. What this means is that if you've not met the goals of the previous phase, just because you're far enough away from your original injury does not mean that you start progressive strengthening or any of the next phase before that tissue and your ankle has met the previous material. So progression without meeting the goals of the previous phase can actually cause setbacks and prolong the rehab and injury. So good communication between you and your therapist during this time is very important. Back to you.
Thank you, Chelsea. So what happens if non-operative treatment doesn't work? I will say about at least 95%, maybe as high as 99% of ankle sprains can be managed without surgery. But some patients, despite being in a boot, wearing a brace, using physical therapy, they have recurrent instability, meaning they keep spraining their ankle. And in those instances, we talk about a surgery. You can see on the picture on the bottom left, that's a stretched ligament or ATF ligament, and a torn ligament. It could be stretched, it could be torn. And essentially surgical treatment is what you might expect, surgically tightening it to restore its natural tension, which can be done a lot of different ways. For high ankle sprains, we're restoring the connection between the two bones, the tibia and the fibula. And as you can see, going from left to right, you can use screws, you can use that device called a suture button, where it's two metal implants on either side of the two bones with suture running between those two bones, or just all screws. Again, the goal is to restore the native anatomy and the connection between those two bones and let your natural healing response kick in. In general, after ankle ligament reconstruction from surgery, there's a general post-op protocol that I follow. You are non-weight bearing for 2 weeks to let the incisions heal. And then you begin full weight bearing at 2 weeks. At that point, you start beginning some directed physical therapy, usually out of the boot into a brace around 6 weeks. And at 12 weeks, you begin starting some sport-specific testing. Your general return to sport is somewhere between 12 to 16 weeks. Everyone's a little bit different, some sooner, some later, but a lot of that determination is made with physical therapy. And this is where I'll have Chelsea jump back in.
All right, so this slide and its progressions are based on Dr. Y's specific protocol. Again, the early goal of those phases are to control pain and swelling, and the patient will usually start PT sometime around 2 weeks post-op after you get out of the splint. There's really not much we can do prior to this. There will be limitations in the motion to protect the repair, but we will be getting you back to moving closer to your normal as much as we can. Motion will be important to meet the goals and progress to the next phase of rehab. In isometrics are exercises where you activate the muscles that you are working, you're activating the muscles, but you're not moving the ankle. These are good to keep the muscles awake and working without causing stress to the healing tissues. Manual therapy is also going to be a big part of my practice during this phase to reduce inflammation, help restore movement, and address the unavoidable stiffness that occurs when you're in a boot for 6 weeks. In that next phase, weaning out of the boot just takes time, and it will be individual depending on the patient. The important part is not to stress and inflame the tissue, resulting in the delays of rehab. This phase will also require good communication between the therapist and the patient to ensure progressive loading of the tissues while avoiding that flare-up. Exercises will progress to more weight bearing, meaning more standing exercises such as standing balance or heel raises. We will also be incorporating balance during this phase to encourage the muscles to be firing and working together, but also to improve your proprioception. Proprioception is the basic ability to know where your body is in space without looking at it. This is very important for the ankle and foot because this is our contact to the ground. Our brains need to be getting reliable feedback from the foot during just about every activity that we do. So working on your balance and progressing through that will be important during this phase to return you to full motion and full activity. And the final phase, again, will be that return to sport or activity. So whatever you outlined during your examination, your initial evaluation with the therapist. And examples of this might be skiing, hiking, pickleball, running, and the specifics of the exercises and routine that you will be doing during this phase will be geared towards whatever sport you're trying to return to. Back to you.
Thank you, Chelsea. So that's ankle sprains in a nutshell. So I'm going to move on at this point to talk about Achilles tendon ruptures. Achilles tendon ruptures, very common in active population, what people quote unquote call weekend warriors, but slowly finding here in Colorado, that's everyone, and regardless of the day of the week. Most common age group is patients in their 30s and 40s, and some risk factors include some baseline Achilles tightness, certain antibiotic use, and steroid use. That can be oral steroids or a previous steroid injection that can all weaken the tendon. In general, the usual mechanism of Achilles rupture is sudden dorsiflexion of a plantar flex foot, which often happens when you're landing. If you look at the images, the picture on the left, the foot is pointed down, and with sudden landing or that heel striking the ground, that results in a sudden tightening and contraction of the Achilles tendon, which with the right force at the right angle can cause a rupture. Oftentimes patients feel a pop, or they feel like someone hit them in the back of the ankle, but there's no one standing behind them. You often have immediate weakness, difficulty walking. Usually it's painful, but after a couple of days, the pain actually resolves, but you're left with some swelling and bruising. These are some common pictures or what to expect on physical exam. On the bottom left, you see the leg on the left, swollen, bruised. You lose the normal contour of your Achilles tendon. And that middle picture demonstrates what's called a Thompson test. So in an intact Achilles tendon, if you squeeze the calf, your foot plantar flex, or in this picture, your foot goes up towards the ceiling. If you have an Achilles rupture, if you squeeze your calf, nothing happens because the connection between your calf muscle and your foot is no longer there. And oftentimes you can actually feel a palpable defect in the tendon as seen on the bottom right. So these are all some common exam findings with Achilles tendon rupture. Now, in terms of treatment, both non-operative and operative options exist, and they actually have similar functional outcomes in the long term. The length of recovery is also pretty similar, somewhere in the 9 to 12 month range to return to sport and return to your baseline. Both non-operative and operative options have some risks involved. And specifically for the non-operative management, there's a slightly higher risk of re-rupture, slight weakness in plantar flexion, meaning heel raise or toe off strength. But the benefits are you avoid the risk of surgery. Conversely, with operative management, you have a lower risk of re-rupture, better restore strength, and allows you to be slightly more aggressive in your rehab, just because you have that confidence and that reassurance that you have rigid fixation within the tendon holding it together. But of course, the risks of operative management include having an incision that needs to heal and going under anesthesia. In general, physical therapy for operative or non-operative management is similar, and I'll have Chelsea talk about it in a few slides. In terms of surgical treatments, there's two main flavors. There's a percutaneous option, which I routinely do. As you can see here, there's a small incision in the middle of the tendon. You percutaneously grab the tendon with sutures and anchor it down to bone in your calcaneus. Alternatively, if that doesn't work or it's a really severe injury, a more formal open repair where you make a much longer incision, but you're able to visualize both ends of the tendon, grab them with suture and tie them back together. My usual repair protocol post-operatively is you're non-weight bearing in a splint for 2 weeks, and you start partial weight bearing in a boot at 2 weeks with heel wedges. And the goal of the heel wedges are to keep your foot pointed down to minimize the stress across the Achilles tendon. You begin physical therapy at 4 weeks, and then over the next several weeks, you progressively increase your weight bearing and remove heel wedges over 4 weeks with the expectation that you're fully weight bearing without wedges at 6 weeks. During that time, you're increasing your range of motion and stretching with physical therapy. You're usually out of the boot at 8 weeks, so roughly 2 months from the surgery. And the rest of that recovery time is working on range of motion and strengthening. So you're doing aggressive PT the remainder of that time. And that's what the bulk of the recovery is getting strong again. And this is where I'd pop it over to Chelsea, and she'll talk about more of the specifics of the rehab.
All right, so PT is going to start about that 4 weeks after surgery. And initially the lifts in the boot will be to help minimize the stretch on the repaired tendon. The patient will be in the boot until about 8 weeks post-op, and this can sometimes be aggravating to other body parts. The boot itself has a rocker on the bottom, but it's also lifted up. So this can be aggravating to body parts like the hip or the back. Patients will often complain of getting some discomfort there from the imbalance of stress. Getting a lift up can be helpful to minimize the stress during that time. It's basically a device that attaches to the underside of a regular shoe, and it just adds a little bit of a lift to kind of level your pelvis so we don't get as much abnormal stress through there. Your other option would be to just wear a shoe with a bit of a heel or even just more padding on the sole. The progression of strength, like Dr. Wise said, is a huge factor in this surgery, as the calf is the main contributor to normal walking pattern and so many other daily activities. So in order to protect the repair, the calf muscle can't be strengthened until you're about 6 weeks out. It's common for the strength to take a lot of time to return. Unfortunately, muscle atrophies or reduces in size much faster than we can build it back. Progressive strengthening will start with resisted or seated heel raises and progress to standing using both legs, and then to one-legged heel raises. That progression will be based on your tissue tolerance and durability. One of the things that might be considered in PT to aid in the return of strength is the use of blood flow restriction. This is the use of a sophisticated tourniquet during exercise. Thank you. To make an easier exercise feel harder, so that the body can build muscle at a rate that might be difficult with an easier exercise alone. So the units that we have in the clinic are called from a company called Delphi. That's the unit on the left. Initially, we place the tourniquet, which is in the second picture, at the thigh. So that's going to be standard regardless of what injury in the lower body you have, whether it's the knee or at the ankle. We're going to put that tourniquet up at as high on the thigh as we can. The device will then measure your blood pressure in that area and will set it to a certain percentage so that it will occlude the blood from coming, as much blood from coming into the leg. And it basically allows that easy exercise, something like laying on your stomach and just flexing your toes up towards the ceiling, which would be allowed as soon as we're allowed to do active range of motion. It would allow an exercise like this to actually be challenging to the calf muscle and start those processes that allow your body to build muscle. So this has been a really useful tool that we've been researching in physical therapy for the last 10 or 15 years now. And so it's becoming more common, and it's definitely something with this surgery to consider. And then that final phase of your rehab will be that return to sport or activity. And with an Achilles repair, it's expected to take about 6 months. The patient will be working progressively on increased loading and increased strengthening during that entire time. You're not just going to be sitting around waiting for 6 months, but it will take a lot of work and consistency to get there. Back to you.
Thank you, Chelsea. So moving on from Achilles tendon ruptures, another common injury I see in the athletic active population are peroneal tendon tears and subsequent instability. And common question I get asked is, what are your peroneal tendons? These are 2 tendons that run on the lateral or outside aspect of your ankle, and they bring your foot into eversion. You can see that on the bottom right picture, what you call up and out position. They bring your foot up and out. Injury to these tendons happen in a similar mechanism to an ankle sprain, meaning inversion of the ankle, essentially the opposite direction of what the tendons do. With a sudden inversion event of the ankle, it can pull, tear, or potentially dislocate those tendons. Those tendons live in a groove behind the fibula, and with a severe injury or severe mechanism, the tendons themselves can tear or pop out of the groove completely. And this is an example of what that looks like. And if you look at the pictures on the left, normally you shouldn't be able to see the contour of your tendon directly underneath your skin. They typically live beneath the bone, but behind the bone. And when you see something like this, it's a sign that your tendons are dislocating. When they dislocate, you often feel a pop on the outside of your ankle, and the pain is just posterior or just behind the fibula, the bone on the outside of your ankle. Ankle sprain pain is more in front of that bone. Peroneal pain is behind that bone. And like I mentioned before, you can often, if we're in a severe injury, feel those tendons dislocate when you move your ankle in a circle. And depending on how bad the dislocation is, you may have to manually relocate the tendon back into the groove with your finger just to get it to stay put. In general, first-line treatment for tears and even dislocation is conservative. It's similar to ankle sprain, meaning you want to start first and foremost with rest, ice, compression, elevation, and anti-inflammatories. But start in a walking boot and be able to transition out of the boot into a brace, and of course begin some physical therapy. And this is where I'll have Chelsea jump back in.
So similar to other rehab progressions, the acute phase will focus on protecting that injured tissue and controlling pain and swelling. Limited range of motion and loading via a brace or the boot is common, like Dr. Weiss said, and the main focus would be, again, limiting the motion so we're not stressing that tissue. The intermediate phase will, again, be progressive loading, working on restoring motion and weaning out of the boot. So being in the boot for any length of time will result in stiffness and weakness throughout the ankle and foot, not just the repaired or injured tissues. Walking is hard when you get out of the boot, and the patient will be needing to take time to normalize that transition. PT is often helpful to guide and to advise during that process. So phrases that I use during this would be heel to toe, pushing off, in order to kind of normalize that pattern. And it's important to do that to reduce the stress and to properly load that lower extremity. That way we don't get issues into the hip or low back, and that we're properly loading that repaired or injured tissue after it's been healing and stabilizing. So the peroneal tendon is very important for balance, and it's how our body will adjust to keeping the foot on the ground. So when your foot's on the ground, your peroneal tendons keep that inside area of your foot and your big toe on the ground. Obviously, that big toe plays a big role in keeping you stable. So factoring all of this in, balance will be a major focus of the rehab, progressing from your double leg balance exercises to more single leg exercises, and then from stable to unstable surfaces. I like to factor in what the patient hopes to return to when selecting balance challenges in the clinic. For example, when runners specifically need to get back to single leg stability. So they would benefit from a lot of single leg exercises that will work on that balance and that proper use and function of that tendon. Hikers benefit from working on unstable surfaces in order to mimic the unpredictable surface of the trail. And again, correcting that posturing of the foot with that heel tendon. All right, and back to you.
Thank you, Chelsea. So as with a lot of things, sometimes conservative management doesn't work. And you may be thinking, well, if you have a tear or your tendons are dislocating, how can your body repair that? It's not necessarily that your body repairs that on its own, but it scars in enough to where you don't feel it anymore. You become asymptomatic. And that's what the goals of conservative management is. But still, with these type of injuries, some people just don't get back to where they want to be. And that's when surgery comes in. If you look at the picture in the top left, that's an evidence of perineal tendon tear clearly through the middle of the tendon. And the way to treat that is what you might expect: suturing the tendon together, repairing it, allowing a surface to where this tendon can smoothly glide through. On the top right, that's an image of a repair of a dislocating perineal tendon. Usually when the tendons dislocate, the sheath that covers the tendons gets injured, detaches from the bone, gets redundant, which allows the dislocation. So by restoring that sheath, either through bone tunnels or suture anchors or a variety of different options, by locking those tendons back in place behind the groove with surgery, it prevents those dislocation events from happening. In general, perineal tendon post-op protocol for me is similar to an ankle sprain, meaning we get you weight bearing in a boot at around 2 weeks. You're out of the boot into a brace at 6 weeks, and then you begin sport-specific testing at 12 weeks with the goal of return to sport somewhere in the 12 to 16 week range. And this is where I'll have Chelsea jump back in and talk about what post-op rehab looks like after the surgery.
So that early phase is going to be similar to the other phases where we're controlling pain and swelling, limiting motion, wearing the boots. So PT will start at 2 weeks post-op and will avoid stretching the tendon and its attached muscle initially. Strengthening in terms of those isometrics is allowed at this phase. And what I like about isometrics is that the patient can control the amount of loading to what is comfortable. These exercises are a really good introduction to some loading to the repaired structures. When progressive strengthening is allowed in that next phase, then exercises will get increasingly difficult and challenging based on the tolerance of the tissues. Indications that the tissues are not tolerating the load are increase in swelling, increased pain during or after an exercise. So we want to be loading that tissue without inflaming it. When the patient is more than 12 weeks post-op and they have met the previous criteria, which is full range of motion, near full strength, good balance, and good tolerance of the activities, especially those during your day-to-day, then we can start to progress into this return to sport phase. There is testing that we can do in PT to measure how close the function of the ankle is compared to your other side. One example of this that I use in the clinic is called a Y balance, which measures how well the ankle does stabilizing when the other limb is moving in different directions. You guessed it, in the Y shape. So you'll be standing on one leg and you'll move an object in 3 different directions, and we'll measure the distance that you're able to move it. And then we'll do that on the other side and compare. Clearance for return to sport with this specific testing, and really any of them, should be at least 90% of your non-involved ankle. So when we're comparing those 2 numbers, that's the percentage that we're looking at to clear you for return to sport. And back to you.
Thanks, Chelsea. And lastly, we're going to talk about fractures. And with sports, with any kind of activity, fractures can certainly happen. They're very common and they can come in a lot of different flavors. So I'm going to talk about 3 general types of fractures. And at the end, Chelsea will kind of go over what to expect in terms of the rehab for them. So ankle fractures, oftentimes mistaken for sprains. They are associated with severe pain, swelling, bruising, usually unable to bear weight. But I've had plenty of patients who are incredibly tough, been walking on ankle fractures for several days, and it always surprises me and amazes me. But in general, I recommend an urgent evaluation to get an x-ray. When in doubt, get an x-ray. You can go to an urgent care or same-day clinic to get that x-ray. And ankle fracture treatment, there are plenty of ankle fractures that can be managed non-operatively. It depends on the location of the fracture, severity of the fracture, and stability of your ligaments. But in general, when in doubt, consult with the surgeon to talk about which fractures can be managed without a surgery and which ones need a surgery. And when it comes to ankle fracture surgery, they come in a lot of different shapes and sizes and varieties. All four of these x-rays are 4 different patients that I've operated on. And as you can see, there's a lot of different ways to fix ankle fractures. It all depends on the way in which it's broken, where it's broken, how bad it is, and what kind of stability the ligaments have to determine what kind of fixation you need. So moving on from ankle fractures, I'm going to talk about another type of fracture that you may be familiar with. It's called a Jones fracture. It's a similar mechanism to an ankle sprain, inversion type injury to the foot. But instead of the pain being localized to your ankle, this is actually located to your foot. You can see here in this picture, the arrow is pointing to the outside or lateral side of the middle of your foot. That's the base of your 5th metatarsal, the bone that's broken in Jones fracture. Again, it's a little further down in the foot than where your ankle would be hurting if you had an ankle sprain or a fracture. So that's the main difference. You'll still have bruising and swelling present, and you oftentimes won't be able to walk on it because of the pain. Just like any other fracture, Jones fractures can come in a lot of different flavors and varieties. The one in the middle is what we call a true Jones fracture. And what determines the Jones fracture is the location of the fracture on that same bone. On the left, if the fracture is further down towards the toes, it's what's called a dancer's fracture. It can actually be managed without surgery. Even if their bone is not quite lined up, your body does a great job of healing it and accommodating any little bit of deformity that's present, and oftentimes does not need surgery. Same thing on the far right, a pseudo Jones fracture. If the fracture is closer to the ankle on the same bone, same thing, oftentimes does not need surgery to fix because your body often does a great job of healing it. But Jones fractures in the middle of that bone don't really do a great job of healing, oftentimes need surgery. The reason it doesn't heal is that area has a poor blood supply. Blood supply comes from the base of the bone and also in a retrograde fashion from the end of the bone, and where it meets right in the middle, where Jones fractures occur, is a tenuous area of blood supply. So if you were to do non-operative management, there's a higher risk of non-union or the bone not healing, resulting in persistent pain and lack of function. So oftentimes I'll recommend surgical fixation specifically only for fractures in that location. It offers a higher rate of union or healing and a quicker return to sport. These are examples of Jones fractures that I've fixed thus far. And as you can see, the way to fix it that I like to use is a single screw through a small incision less than 1 inch in size. And what it does is, one, it provides stability to the bone to prevent the fracture from moving, but also the act of placing the screw actually stimulates healing and blood flow by debriding the bone as the screw goes in. So, and just by having surgery, it will stimulate healing for you. Lastly, I'm going to talk about Lisfranc injury, which is an injury in the middle of your foot closer to your big toe. What then you can see on the x-ray here, that gap between your 2nd metatarsal and the 1st metatarsal, this space here, that's a sign of Lisfranc injury. It's usually caused by an axial load when you're on your tiptoes. So if you're standing and someone hits you, tackles you, falls on you, and you land directly onto your toes, it can cause an injury to the middle of your foot. On the diagram to the top right, that ligament here, that's what keeps that area intact. But if it's disrupted, it shifts the whole middle of your foot over away from your big toe. And oftentimes patients here pop, just like other major injuries. You get swelling throughout the middle of your foot, which is much more significant compared to the contralateral side. You get pain in the middle of the foot, and you oftentimes get bruising and swelling on the bottom of your foot. And as just like most fractures, you have pain with weight bearing, oftentimes unable to put full weight on it. So what happens if you let it go? There's oftentimes no real fracture associated with it. It's just a ligamentous injury. But with the whole middle of your foot shifted over in the wrong direction, over time, you'll develop arthritis in the foot. So the picture on the left is a sign of an acute Lisfranc injury just recently happened. But on the far right, you see what's signs of midfoot arthritis, where all those little black arrowheads show joint space narrowing, bone spurs forming. And it's whether or not, it's not a question of if you'll get arthritis, it's a matter of when. It's just going to happen at some point, because again, if you're having these injuries, you're pretty athletic and pretty active. So just from wear and tear over time, you usually develop arthritis in the middle of the foot. Surgery should treat Lisfranc can come in 2 main flavors, either just fixing the ligament with 2 screws, as you can see on the left here, with the intent that the screws keep the bone in a good position and your body scars in that ligament naturally, and those screws eventually come out. Or for more severe Lisfranc injuries, it involves a fusion. And as you can see, this bomb of screws in the middle of the foot, It's the goal of that is to fuse the whole middle of the foot, prevent that foot from shifting over, and those screws stay in indefinitely for a long time. So in general, post-op recovery after surgical repair of fracture, regardless of what type of fracture, just totally depends on the type of fracture, severity, and bone quality, but almost always involves some period of non-weight bearing immobilization. As Chelsea has been talking about, healing from surgery, bony surgery, soft tissue surgery is a delicate balance of letting things heal, but also preventing stiffness. And we initially immobilize you, prevent you from walking to let things heal. But as soon as we can afford to let you become more active, we let you do so to prevent stiffness, prevent atrophy, get you back to where you want to be. So as time progresses, you have progressive increase in weight bearing as fracture heal, and then you will require physical therapy at some point post-operatively. Again, depends on the type of fracture to get you back to where you want to be. And this will all have Chelsea jump in and talk about fracture rehab.
So with fractures, the important thing is that we're setting up that good environment for healing. There's plenty of factors that we can't control, but the ones that we can are going to be that stress through the fracture site by limiting motion, limiting weight bearing, and immobilization. So we want to make sure that we're encouraging circulation during this time. Manual therapy can help with this. Also controlling your swelling, and the use of a boot or cast can help with this. Once you're out of that acute phase, the patient will start to transition from the boot. Exercise will also gradually increase, and you'll start returning to your daily activities. Key during this is to, again, monitor the tolerance of the bone as the increased loads and as you're spending more time on your feet and as you're doing more things around the house. Similar exercises to focus on strength and motion and balance will be incorporated into your home program. The focus initially is on restoring that tolerance to daily activities and walking. And then once the patient is the appropriate amount of time from the fracture, there's good healing and the tissue is tolerating those loads on it, then you can start that progressive strengthening and return to sport activities in a manner that was similarly discussed. Back to you.
Well, on behalf of Chelsea and Sally, I want to thank everyone for taking the time to sit down with us, talk about foot and ankle surgery, the rehab involved. And I look forward to being able to helping you guys get back to where you want to be, maintain your active lifestyle, and continue to serve the community. So at this point, I'll open it up to questions. I think Sally will take over that, and feel free to ask any questions on your mind, anything related to this, even not related to this. Happy to answer them if I can. Thank you, guys.
Okay, and if you have any specific questions, go ahead and you can, I do have Beth here who has raised her hand. So I'm just going to go ahead and let Beth ask you that question. So allow Beth to talk. Go ahead, Beth.
Hi, I had 2 years ago, I broke both of my bilateral tib fib ski accident here in Vail. That's where I am. And I just now got the last of the hardware out. I had an IM nail removed last week up here at Stedman. My ankles are still so tight, especially obviously the one that I didn't have the nail in. The other one, I had the plate removed last April, but the outside of my ankle is just so stiff and tight. Is it ever going to go away?
That's an interesting question. How long ago were the injuries?
February 8th, 21 is when I had my fall, and neither ski released. So I had in my right leg, I had a spiral and it did not heal. So they ended up putting the nail in after they took the plates off, which were broken. So I've had 7 surgeries now. And
my goodness, that's really impressive. Those are no joke injuries. Those are pretty severe. But to your question, it's been almost 2 years from your injury now. And at this point, it's probably going to be difficult to get that same motion back. Okay. The bulk of range of motion and stretching typically happens in the first several weeks to a few months after the injury. Mm-hmm. It's hard to get that back this far out. Now, depending on how severe your range of motion and your stiffness is, there are special types of surgical releases to release some capsule or other tight tissue around your ankle that could improve it. But that's only if the stiffness is really severe. Okay. And if you have difficulty walking as a result. But it's going to be difficult to get that back this far out from the initial injury.
Right. Well, thank you very much. I'm going back to PT next week at Howard Head because of this surgery I had last week, but I don't know, maybe she can figure something out.
It's never a bad idea to continue physical therapy, even
Right,
after
right.
years. Yeah, of
Thank you so much.
course.
All right, thank you, Beth, and we're gonna go ahead, and Barb has a question for you. Go ahead, Barb.
Thanks, Ellie. So what could be possibly going on if there's not an actual injury or like a moment of a big ow or something happening when the front of the ankle, meaning where my leg connects to my foot in like a semicircle, creates pain when I walk?
So that's an interesting question. If you didn't have a discrete injury, it could be a couple of things that could be causing it. It could be development of some early arthritis without an obvious injury that causes pain. That's a consideration. It could be some amount of tendonitis, and injury doesn't necessarily have to cause tendonitis. It can oftentimes be from overuse or being very active. You can develop inflammation or irritation of that tendon. So it could be tendonitis. Alternatively, it could be what's called a stress reaction or overloading of the bone, similar to tendonitis, in that if you're very active, being on your feet and ankle often, you can cause your bone to develop injury, bruising. That's one step below a stress fracture, but can still have a lot of pain. So any of those three things could be potentially what's causing those symptoms. And the easiest way to find out first is to get evaluated by someone to do an exam and then get an x-ray. And even if the x-ray is normal, doesn't show a fracture, may show arthritis. Or if it doesn't show arthritis, it helps you lead you down the path, maybe a soft tissue issue.
And if there's no swelling, that was the thing that has me, I like why I didn't come in, because it comes and goes and there's no swelling or discoloration. So is that something that would fit with the arthritis?
Potentially, yeah. Arthritis, unfortunately, presents in a lot of different ways, and it's different for everyone. Meaning, there can be patients with really severe arthritis on X-ray, but they have no symptoms. Vice versa, you can have mild to moderate arthritis on an X-ray and be in debilitating pain. So there's no rule of thumb when it comes to arthritis. There's no one size fits all for that. Everyone's a little bit different, unfortunately. But in general, if you're questioning whether or not to come in, if your symptoms, pain, swelling, whatever it may be, is severe enough to where you can't do what you want to do and it's limiting you, then it's worthwhile getting evaluated. Because the reason I exist and my partners exist is to keep patients active. And if you can't be active and doing what you want to do, then it's worthwhile coming in and get evaluated.
Okay, thank you.
Okay, thank you, Barb. Okay, this next question is from Alex, and he has put that in the Q&A, and his question is to please comment on total ankle replacements and your thoughts on those.
Sure. Total ankle replacements, just like hip replacements and knee replacements, are treatments for severe ankle arthritis. Back in the day, and I'm talking 15, 20 years ago, there were some primitive early total ankle replacements out on the market, but they were pretty early on. Most people were treating end stage ankle arthritis with ankle fusions, where you lose the up-down motion of your ankle. Patients did well. They had improvement of pain. They were back to what they want to do, but they lost a lot of motion. So since then, we're now on the fourth generation of total ankle replacements, these specific implants, and patients are doing really well from it. And I reserve it for patients who have really severe ankle arthritis and they've tried everything, but when it gets to that point where it's really severe and limiting, patients tend to do really well. And it's, again, similar to a knee replacement where you remove the ends of the bone where the arthritis is, replace it with metal components, and have a plastic spacer in between that acts as new cartilage to allow motion. You're not going to have the motion go back to where you were when you were born, when you were younger, but you still maintain the motion you had before the surgery. So It's a benefit in that way. It prevents arthritis from adjacent joints because you maintain motion and you don't fuse it. So I'm a big believer in it. And anyone with end stage arthritis, I recommend an ankle replacement and not a fusion.
Okay, thank you. And we have another question from Emma. And Emma says she had a Liz France injury almost 7 years ago and got 3 screws in and removed 3 months after the initial surgery. After continuing to play soccer both competitively and collegiately for 5 to 6 years, I have developed osteoarthritis and often have pain, very similar to the original injury. I still want to be active and exercise a lot, but I'm not sure what to do to prevent the pain.
Yeah, so that's a tough issue. And just as you described, Emma, even if you've had an injury and then had surgery to restore the anatomy, the severity of the injury itself may be enough to develop arthritis. If you're at this point now, 7 years out from the injury with arthritis that's present, there are a couple of things you can try. And you may have already tried these. You can try more supportive shoes. You can try supportive orthotics that provide cushioning and arch support right in the middle of your foot. After that, you can potentially try a steroid injection. And in the foot, there's a lot of tiny joints that are hard to get to, but with image guidance nowadays, with an ultrasound, we can actually get kind of specifically to the joints that are in pain and in question and try to provide some relief. What corticosteroid or cortisone, what it does is a really strong anti-inflammatory effect. And by injecting it right into a joint, it focally provides that anti-inflammatory effect right where the source of your pain and symptoms are. And that's the gist of it, unfortunately. You can also supplement with anti-inflammatories, but that's what you can do. And if you've tried those things and the pain is severe enough to where it's limiting you and you can't do what you want to do, then we can talk about a surgery. And in this situation, when you have arthritis, surgery involves a fusion of the middle of your foot. It's not nearly as debilitating or limiting as an ankle fusion in terms of loss of motion, because the middle of your foot doesn't have too much motion anyway in terms of your normal gait and the way you walk. So you'll be able to, or should be able to, get back to where you were before the injury, but there is a significant recovery associated with it, somewhere in the order of 3 to 6 months to get back to where you were before. So I don't take surgery lightly. I don't recommend surgery to anyone that comes across me, but I would first try those things: supportive shoes, orthotics, anti-inflammatories, maybe a cortisone injection, before talking about a surgery.
Wonderful, thank you.